Welcome, everyone. Hello. I see some names from yesterday webinar, which is good. So today is the second part of a series of webinar that we are hosting on transition in healthcare. Yesterday, we focused on how to turn evidence to implementation and setting the scene at the different levels. And today, we will go deeper into what actually ERNs are developing in terms of tools and resources for an effective transition. So before we go into the discussion, I would ask you to please mute yourself and turn on your camera if possible, add your name if it's not visible or in the chat, and use the chat for Q&A and for comments along the session so we can have a vivid discussion. The meeting is being recorded and it will be published in the EURORDIS website. So I'm very happy today. I'm very glad to present the agenda for today. We will have Caroline Love. She's a doctor and EPAC lead in ERN ERNICA, and she will explain how they are building capacity of adult services to receive transition patients. Then we also have with us 3 representatives from ERKNet, Karsten, Anna, and Simje, and they will share with us how they are developing a transition passport for rare kidney diseases, how they set up the working group. Also, they have some news on a newly set up youth panel in the network as well. Finally, we will have ERN RECONNET representatives. We have Silvia and we have Moja. Together with ERN Rita, they have developed a transition care course, and they will explain us about the methodology and how they plan to have these course running this summer. So with no further delay, I would like to give the floor to Caroline Love, please.
Yeah, Nora, can you...
Let me stop sharing so that
yes.
you can... Yeah.
Thank you. Where is it? Oh, there we go. And from the beginning.
Perfect. We see it.
All right, so I'm Caroline Love. I'm a EPAG for ERNICA and a dermatologist by my day job, as Nora mentioned. Today I'm going to discuss how we plan to build capacity of adult services within ERNICA. So for those of you who don't know, ERNICA, we all know what an ERN is here on the call, a European reference network, but we specifically represent those with rare, inherited and congenital gastrointestinal anomalies. And that means anomalies, for those of you that are interested, such as esophageal atresia, necrotizing enterocolitis, gastroschisis, Hirschsprung's disease. ERNICA membership is essentially paediatric surgeons with a small number of gastroenterologists, respiratory physicians, most of which are all paediatric based, and very few adult clinicians and specialist nurses. We have some factors that we share with Eurogen that make transition more difficult. When the condition is diagnosed, at birth, usually we're referred to paediatric surgeons and usually stay under them throughout our paediatric course. However, unfortunately, we usually need to transition to other specialties at time of transition to adulthood, such as gastroenterology and respiratory physicians. And that makes it harder to find clinicians that are aware of the condition, and for these surgeons to make links with these clinicians, particularly because they're based in children's hospitals, so it's hard to find adult clinicians outside of their specialty area. A big problem throughout the transition system, not just in ERNICA, is that although there's a lot of focus on transition process, preparing young adults for transition, the destination is often unclear or not present. Particularly for us, we only have 2 clinics across the whole of Europe, or 2 adult physicians with special provision for long-term sequelae of these anomalies. And they both represent esophageal atresia and congenital diaphragmatic hernia, which means that most of the conditions represented by ERNICA have no formal services within Europe at all. Most of our patients are discharged to primary care at 16 or 18, if not before. And if there are transition, as I mentioned, it's to adult GI surgeons, which is often not appropriate. Why does a transition destination matter? Across all of the conditions, it's shown that poor transition leads to poor adult outcomes. So there is published data in conditions such as congenital heart disease and diabetes that those who aren't transitioned well or don't engage with transition later present back to adult services in extremis or with morbidities as a result of not being followed up. There's also, if people are discharged at 18 and there's no obvious referral pathway, there is what one paper described as a prolonged diagnostic odyssey. Primary care doesn't know where to refer them. They may refer them to the wrong specialty, or even if it's the right specialty, they don't recognise that the symptoms are related to their original condition. And that means that they get unnecessary tests, misdiagnoses, and unnecessary treatments before they finally reach the correct diagnosis, if that does happen. An additional factor with surgical anomalies is that our anatomy can be different to what adult clinicians are used to, and so they may find interpretation of their investigations, and if they do any surgery, they may find that what's inside is just not what they're expecting. So our approach was to form a transversal working group of 4 core members and 1 project manager. Uniquely, 2 out of 4 were patient representatives. 1 was myself, and 1 who you may know, who's a very well-known volunteer, is Graham Slater. And we subdivided this into vision, transition, and adult care. So the transition subgroup addressed the usual areas of transition, preparing young adults to take control of their own healthcare and educate them in their condition. They looked at the existing literature and looked at how they optimise preparedness of the team to move to adult care. My subgroup looked at how we got young adults and adults who were discharged to the right destination, and how to develop referral pathways so that paediatric specialist services, secondary adult care and primary care knew where to send them to if they came to them. And we also felt that a multidisciplinary approach is needed because most of these conditions cover several specialties. The vision subgroup was a more interesting approach. Graham and Raymond Goethe wanted to think outside of the usual immediate transfer of paediatrics to adult system and think in terms of lifelong care outside of that. So where are we now? We've written a series of position papers. The transition team are aiming for a warm handover. They're looking for structured transition framework starting at 12 as an age appropriate way of doing this. So initially educating them about the condition, moving towards discussing lifestyle such as alcohol and cigarettes and how that may impact their chronic health problems, as well as sexuality, pregnancy and fertility at a later age. They want to develop disease-specific transition standards within ERNICA, a transition app and a patient passport. And that's an example of our transition app that they want to develop. And so that would have all the information for the patients about the plans of their transition over the next few years, so that the patients are aware of what's going to be going on from a young age. The adult subgroup, as I mentioned here, want a place to call our own, and how we would envisage this happening is through initially use of the ERN-wide CPMG model to use a virtual MDT for adult care, and that would form education for adult clinicians as well as improving adult care in the great majority of Europe without any adult services. We foresee adult services in each country as one clinic with 3 different adult services, one representing thoracic anomalies, esophageal atresia and congenital diaphragmatic hernia, midgut, gastroschisis, neck, and the like, and lower GI such as Hirschsprungs. So 3 different clinics, but one in each country. Identification and education of adult physicians, because adult physicians aren't going to know what the long-term health issues are for these different conditions. So we need to empower them to treat us. We realise that there is very small numbers of some of these conditions, particularly in small and underdeveloped countries. So we would want to create a twinning or system, as happens in cystic fibrosis and respiratory care, with the smaller countries, so they can be seen in their own country and language, but still get expert care from centres of excellence. The Vision Service wants to develop an MDT across the lifespan, with patients affiliated with one centre of excellence throughout their life in the best place for them, not the healthcare system, because they may still need paediatric equipment to investigate them due to their anomalies, and the paediatric surgeons are the best place to know what their anatomy is, and it will integrate the expertise in one care network. So how we plan to expand adult services, this quote is misattributed to Abraham Lincoln, but I thought it fit well for what we plan to do. Immediately, we want to discuss and ratify our plans with our wider transversal members and publish our position papers in 3 parts in a journal for dissemination across the networks. We know that through our existing research, there are 7 other ERNICA centres with informal adult care, and we want to look at why those were established, what works well, and how this was initiated so that we can extrapolate this going forwards. Medium term, we want to develop the digital passport and app for the transition and the transition structures and protocols, set up the CPMG adult care MDT sessions, develop the adult protocols, and the key point here is to formalise the adult care clinics in the informal care centres currently, and then this will allow us to hopefully springboard from this to doing this across Europe over time. So as Buzz Lightyear says, to infinity and beyond, what we would like in the end is for structured transition for all young adults. We want adult clinicians to run adult clinics, and we need to train them to do that, and that will require funding to do so that they can travel to adult clinics. Some of the training will be through CPMG, but some of it will be going to paediatric clinics that already exist, going to the adult clinics that already exist. We want to learn from the process of formalising our clinics, and as I say, we want the adult MDTs in each ERNICA, larger country at least, representing these 3 subdivisions. Even more long term, we want to break down the barriers between paediatric and adult services to represent lifelong care, and develop the twinning for less populous or developed countries, because some countries will probably only have half a dozen patients with each anomaly, and so it's just not practical for them to have their own clinic for these things. So I hope they find that useful for you, and any questions you want to ask.
Thank you very much, Caroline. Thank you for sharing this strategy that you have developed together from the EPAC perspective and the clinician's perspective and the ERNICA coordinating team, and particularly the focus on the building capacities and empower, as you mentioned, adult services, because sometimes this is missed. So do you have any questions maybe in the chat? Or I see Anne, you have one?
I do, yes. Thank you. Thank you, Caroline. That was really interesting. You mentioned, or I saw at the bottom of one of your slides, a care coordinator. How far along are you with that? We've established a care coordinator in our paediatric service and working very hard to make this a life course thing, and to get an adult a coordinator in the adult space, but we're finding it really difficult. I'm in Ireland, by the way, and also, like, given that there's thousands of rare diseases, how are we going to make sure that every condition is looked after in this way. That's for me, care coordination is key. But I'm just looking for your thoughts on it.
I mean, I think for us, we're not as, I mean, it sounds like you're further along than we are with that development, but I think the coordinators would, again, fall into the, I mean, for us, it's relatively easy to split our rare diseases into these 3 subdivisions. And so I would foresee the care coordinators covering these 3 subdivisions of thoracic and midgut and lower gut anomalies. And so even though there'd be a fair few anomalies within that, many of them overlap in terms of their symptoms and conditions in any case. So I don't, obviously having one for each condition isn't practical, and would be extremely expensive. But
it would, yes. That's why I'm wondering, should we be advocating more fiercely for care coordination?
I think it's very difficult, I think particularly from our point of view, because I mean, it's difficult across the board, I think, for adults with complex conditions to necessarily coordinate and manage their care. But I think particularly if there are multiple specialties involved, then it's essential to have a care coordinator so that they can liaise between the different specialties and build those relationships as well between the specialties. I think.
I absolutely agree with you, Caroline, because I've seen it work here. Now it's not perfect and it's not being resourced properly, but it's working, and it's working for the families. So I don't see it being any different for in the adult space, you know.
Thank you, Anne, for raising this important topic. Ines, please.
Yes, thank you, Caroline, for the presentation. I love this. I love the kind of the some of the vision that you've just shared with us. So this thing about a warm handover and the idea of treat them in the best place for them, not for the healthcare system. So my question to you is really kind of, I know that ERNICA has been working on transition for a long time. So for the ERNs that are kind of now starting their process and doing their surveys, etc., I'm wondering how long did it take you to get from the first initial I would say a research around transition and getting the community and the EPEG and the ERN working on this topic to what you have now, which is a clear vision, clear projects, and deliverables that you are presenting today. So a little bit of, if you can explain to us the journey that you've been through. And the other question is more around if you've thought about how, because you are working with the clinicians and you are with, in the ERN ecosystem, which is clinicians and patient representatives. But then for this to, be something real and scalable, etc., you would need to engage with the health authorities. And to make these clinics real in the countries where everything you've just explained, you need to kind of bring the health authorities into the picture. So I'm just wondering if you've thought about this and how you envisage to go to engage with this kind of very important stakeholder in all this. Thank you.
Taking your first question, I think it's been about 8 years that we first started doing surveys looking at the transition process and publishing. I think we published in 2021 the first paper about our transition, the transition or absence of it across the European Centres of Excellence. And there was a more recent paper 2 years ago looking at that as well. We started the transversal, I want to say 2 years ago, and had a meeting about 18 months ago with the whole transition group. To be honest, from my point of view, working with another patient representative from Eurodis, Dalia Aminoff, the actual, not Eurodis, Eurogen, the vision for adult care actually came out pretty easily, and I think there are models of adult care existing in highly specialised services in the NHS as well as that we could remodel it on. I think we had a clear idea of what we wanted. It's just how to get there from here. Sorry, I've forgotten your second question. What was the second part of your question?
The second part is how to make
the
this
health authorities. Yes, yeah. I think that's what we want to do with the explore with the formalisation of the 7 adult care clinics. So we know we're going to have discussions with the health authorities and look at the funding in each country. I think our concern is that some of the existing adult services have been driven by big personalities that have the ability to persuade, that are very dominant in their individual hospitals. And so what we also want to make sure is that once we get the logistics of the healthcare service sorted out, we also don't want people to retire and then the whole thing to fall into nothing as well. There needs to be sustainability for that service as well. So yeah, I mean, I think we're very aware of the fact that we will need to negotiate with the different health authorities, and so that's why we're starting small by formalising these 7 clinics and then learning from that how we move that forward across the rest of Europe. Most of the informal clinics are in 2 or 3 countries, so it's probably even 2 countries. So we can do it in a small way and then move forward to the rest.
Thank you.
Thank you, Caroline. Thank you, Ines, for the question. Do we have any more questions to Caroline? I may have one regarding the virtual multidisciplinary teams that you mentioned, because you also mentioned that there is not enough specialists in adult care for the conditions that ERNICA cover. So how do you foresee to cover this gap of having these virtual multidisciplinary teams, like building capacities? You mentioned about empowering clinicians. So if you can maybe share about that.
Yeah, I mean, I think we have amongst us, there are people we know, adult gastroenterologists, adult respiratory, adult gynecologists, and urologists that are already on board. So we would and they're already heavily engaged with the adult care and trying to improve it and normalize it. So I think obviously they would join the MDT to start with, and then it's also, I think Dr. Campus and Professor Spander in the Netherlands, they've really they set up the first adult clinics for ERNICA, well, not for ERNICA, but that within the conditions within ERNICA, and they really talk about how they've had to talk to their colleagues, not just locally, but within their national societies to normalise this. I mean, certainly from an esophageal atresia point of view, as that's what I represent, Dr. Campus and I have been looking at sort of approaching the respiratory society, doing seminars, getting symposiums in the seminar just to diversify the number of people. We've already done some of that, but we need to replicate that across the other specialties to raise awareness of the conditions we cover and to gain adult physician buy-in to the fact that we need long-term care.
Thank you, Caroline. There is a lot of work behind the scenes for each of these points to happen. Okay, so thanks so much, Caroline. I will now give the floor to our next speakers. We have Karsten, he's EPAC advocate at ERKNet, and we also have Sinje and Anna, they are project managers in ERKNet. So please, the floor is yours.
If we can make it full, yeah.
Yeah, it works like this. Okay.
Yeah, perfect. Thank you, Karsten. Well, thank you so much to Eurordis and to you, Nora, for inviting us to this transition webinar series. We are representing a European Reference Network for Rare Kidney Diseases, and we have our transition task force as part of our grant. I want to say it has been active almost 2 years. And in our transition task force, we have approximately 9 nephrologists and 2 geneticists and 5 EPEC representatives. And this is the representation of the chair of the task force, with Carsten being an EPEC representative. And it has been great to help his support, especially for youth panel and his experiences in the transition. If we could go to the next one, please. So the transition task force exists because we want to improve the transition from pediatric to adult care services. And our plan is to design or co-develop practical communication tools that can minimize gaps in clinical handover and promote continuity of care. And we decided to do that by developing a transition passport. So maybe we can go to the next slide. So the transition passport idea didn't come out of nowhere. So we basically attended the workshop called Transition in Rare Disease Workshop in Ghent last February. And transition passport was the outcome of that workshop. And it was highlighted as a need, as a tool that can minimize the, gap during the clinical handover. It is basically, a transition passport is basically a structured document that brings together medical history, contact details, and like most important surgeries of the patient. It is aimed to make the process easier, transition process smoother for both clinicians and patients, that it would give somehow information to patients about what to communicate to the new adult care team, and that also it will also give clinicians a clear picture of the patient's journey. So we went straight ahead to the clinicians across ERKNet and our EPEC representatives to gather their perspectives and insights about what the passport should look like and what content we should include. So when we just look at the results, it's basically the survey, I think, contained approximately 30 questions, but we currently included here a brief survey results for the sake of time. So when we look at who completed the survey, we actually received an excellent response from our clinicians. So as you can see, approximately 110 clinicians responded to our survey. So they gave us like a solid foundation to build on. So 60% of them were pediatric nephrologists and 35 of them were pediatric nephrologists. And regarding patients and families, our sample size was unfortunately a bit low, and mainly the patient group were parents or carers, but not the young patients themselves. So the results mainly reflect a carer perspective rather than the patient experience. If we could go to the next slide. Yeah, and our first question in the survey was that whether their center currently use a structured transition tool, or whether patients and families experienced the use of a structured transition tool. As you can see here, 43% of the clinicians or centers have no structured tool, and that was the most common answer. So it clearly highlights a gap in there. And also 37% of the patients received nothing structured at their own transition. You could go to the next slide. Yeah. So we also ask about the passport content, as I mentioned before. We ask participants to rate on a scale of 5 how important each item was. So from the clinician side, as you can see, current medications with monitoring needs, confirmed diagnosis, transplant status, patient's full name and date of birth, current kidney function were the most highly rated ones. And from patient sides, there is also some alignment, and patients would like to see their genetic test results and family history, and they want to see a summary of how their condition has progressed and their confirmed diagnosis, their current medications, and their current kidney function. So basically all items that we provided in the survey were rated high, as you could see here. We also asked them whether we should include genetic molecular diagnosis information. There was differing opinions here. Well, the clinicians wanted to see a full genetic details or a reference to a genetic report, whereas patients wanted to see a brief summary of the genetic test results. We also asked which contact details we should include in the passport. So when we look at the patients and family sites, with 100% certainty, patients named the contact of the referring pediatric nephrologist and the name and contact of the new adult care team and emergency guidance were rated as definitely essential. But when we look at the clinician side, they thought that contact of the referring pediatric nephrologists were more important, and receiving adult nephrologist name and contact were seen also important with 84%. And when we look at the emergency guidance, there is a bit of a differing opinion here. The patients thought that it would be quite important to have emergency guidance in the passport, whereas for clinicians, this wasn't rated as super important. So we also asked about design and format and language of the passport, and my colleague Carsten is going to mention about those results.
Yeah, I will take over. Thank you, Simge. So other questions that we asked the participants was whether we should provide a transition passport as one generic passport or whether as a disease-specific version. And I think there was kind of a consensus that actually physicians as well as patients preferred more like a generic passport, but with the possibility or the opportunity to actually add specific pages regarding the disease-specific information. Then if we ask the participants who should fill in and keep the passport up to date, the healthcare providers mainly said it was a responsibility of the pediatric team that should provide the information for the transition passport, whereas the patients actually were quite unsure, but they actually more like favored a shared responsibility between the care team and the patient themselves. So it might be a good idea if you want to implement a transition passport that actually the pediatric team takes the initiatives, and that eventually the responsibility to keep the passport up to date becomes like a shared responsibility in the later stages of the transfer or the transition. We also asked the participants when the transition passport should ideally be started, and there was a consensus between the professionals and then the patients with a starting age around the age of 14 to 16, so definitely before the transfer, but not that much before the transfer. So they didn't recommend to start with the transition passport from the age of 12, but rather later in the stages at the pediatric department. We also asked the participants in which format this transition passport should be practical and useful as well. And healthcare professionals, they were mainly, or they favored actually just a fillable PDF document only, which is very easy to organize, to perform, to conduct, which can be saved, stored, and printed very easily. Whereas patients and families, they rather had like the combination of both a fillable PDF document, but also a very small compact card with the most essential information that they could take with them to all the other consultations or any other contacts with professionals. And then I will go to the summary and the next steps, and I will give the word to Anna.
So we decided to now work on this passport and to set up something in the beginning, close work together with our youth panel, which is also in the works, but also our working groups, also highlighting different needs for different disease groups. So we want to now create a PDF, which will also be then checked by our transition task force, but also, like I said, by the working groups and by the EPECs and the youth panel. But it also has to be a work in progress. So we will keep refining it and we'll keep updating it to then essentially highlight what is most important for the specific disease groups to support their transition effectively, the patient and also the clinician. So both parties have to be supported in this transition step. The goal now, as Carsten has mentioned, is a PDF. Depending on the next funding periods and the next ERN periods, we also aim to then have a version that we can maybe use more digitalized, especially for younger patients. How that will exactly look will obviously still be discussed and still be figured out, if it's an app or if it's something on the website with a login or something. That's still very much out in the open. So for now, it's just creating the passport, creating documentations, maybe to go along with it, or informations, and moving forward with that and kind of working at it and improving it.
And I will take over then. As we already mentioned, only 12 patient representatives or representatives of patients or patients themselves have participated in this survey, which clearly identified the gap that we do not have yet included the perspectives of young people. I think within ERKNet, I'm currently the youngest EPEC, and I'm 34 years old, so I don't consider myself young anymore, and I can definitely not identify with young people that are 16, 17, or 18 years old. So that's why we think it's very important for ERKNet, but as well probably for any other ERN, to establish a youth panel and to recruit patients that are aged between 16 and 25, 30, or 27 years old, so that at least their voices are heard in initiatives such as, for example, the development of a transition passport. What we are looking for within ERKNet is young people aged between 16 and 27 with a rare kidney disease. The age of 27 may seem a little bit weird, but actually we had some discussions whether it should be 25 and 30, and we just found middle ground in 27, which is actually the reason why we want to recruit patients between 16 and 27, and they should have like a basic proficiency in English, not a good proficiency, but a basic proficiency is sufficient to join. What will our youth panel especially do or work on? We already have some suggestions from ERKNet, for example, provide feedback about the transition passport, infographics, other materials, how the transition passport should look like, whether an app is relevant or not relevant, whether it will be used or not. They will also contribute to the task force decisions at any stage, especially the transition task force, and create content on social media. Now, of course, these are only suggestions from ERKNet. I think it's the most important that we build our activities based on the needs and inputs from the youth panel members themselves. So that's why we are organizing or having a first transition task for a youth panel meeting mid-July, so in a couple of weeks, where we will just have a meet and greet between the young people and the coordinators, which are Simge, Anna, and me. And we will discuss and brainstorm about the scope of the youth panel and just listen to the youth or the young people what they would like to work on in the next couple of months and years. Also important to mention, currently we have 10 very engaged and motivated young people, but if there are any other young people that are willing to join the transition task force, please reach out to Simge, Anna, or me. And then I give the word back to Simge.
Yeah,
or
thanks,
Anna.
Carsten. So I just wanted to do a call out here. We still have the survey accessible and active. And in case you know any family member or patient with lived experience of a rare kidney disease, and if you're interested in taking part in this survey, please contact us via this email address so that I can share the link with you to the survey and you can take part. As we mentioned, we would very much appreciate the feedback and perspectives of patients and families to improve the content of the transition passport. Yeah, I think that's.
Thank you very much, Sibje, Anna, and Karsten, for sharing first the methodology, how you are developing the passport, how you foresee the next steps, and also a call for other ERNs to maybe have a youth panel, which I think it's a great idea, and to fulfill the gap of having more patients in your survey. Are there any questions for Simje, Anna, and Karsten? I see one on the chat. Maybe you want to say it out loud.
I can also answer it, the one that was in the chat.
Okay.
As I've read through it. So the problem with the electronic health records is, as Ines has also mentioned in her comment, it's still not interoperable between different institutions and different healthcare providers and even different countries. They all have different standards. They use some different systems, and they also don't completely use the system yet. So as we've noticed in the transition workshop, but also when we did the survey, a lot of people still have mentioned or have indicated that they don't have a structured transition tool in place. So for us, it was clear that the need for one was still very valid, even with the electronic healthcare records in place, as well as rare diseases are not yet that well represented in the electronic healthcare records. And oftentimes you have to scroll a lot, you have to read through a lot of stuff to even find places to put things like genetic data or stuff that needs to be entered in these records. So for now, at least, this passport still seems like a relevant option, especially considering the survey results and the workshop results, again, from this February.
And if I can add to that, Anna, there's also a difference between like just health data and psychosocial data. And I think the transfer of psychosocial data is not that easily performed or conducted within the transfer. So that's why Transition Passport can both include data from the electronic health records as well as psychosocial data that should be transferred to the adult physicians.
And it'll also support the patients themselves in taking charge of their disease and being active in the transition process, which the electronic healthcare records don't necessarily do. And that's also one of the goals we want to reach with the passport, is to get the patient more involved with their own disease and get more knowledgeable with what's going on and what they need to watch out for.
Thank you, both. Ines, please.
Yeah, just to mention that, yeah, I think it's a valid point, to be honest. I think that if I were someone working in the Ministry of Health and trying to set up, or in a regional health, regional health authority, trying to set up a transition pathway, I would probably, because I would probably look at what information needs to be shared between the different, different institutions, organizations that are being involved in that transition pathway. So the thing here is that, see, if we look at the passport as an isolated project, which it is at the moment because it's a project within the ERN, etc., it can feel a bit like, but I think it's also useful for policymakers when they start looking at actually implementing care pathways in a very specific way, and they can use all this work to define what information needs to be shared, what systems need to talk to each other, because as Karsten was saying, maybe it's not just the electronic health record, but it's a bit more complex, and other systems are in place. So I think that it is, it's a very nice, I'd say, element that can be taken into consideration by people who are actually working on defining and implementing this on the ground. And but for now, I do think that yeah, it is very useful, because the reality that we have today, and maybe for the next few years, is that there is not a real interoperability in most countries. So yes, yeah, I just wanted to say that I also think that is kind of a piece of a more complex puzzle. But anything that is, already put together, it's evidence-based, etc., will help anyone who is who will be, designing this more at a scale or in a country. Yeah, so that's just my comment on this.
Yeah, and
Thanks.
as you mentioned with the puzzle, I think that's a very important point. And it's a big puzzle, it's a piece of it. But the point I think is to start the puzzle somewhere and to like
Mhm.
start something and then get experience from that, and then also have some real life evidence and some data that we can work with and see what worked, what didn't work, how can we change this. But that was what was important for us specifically, is to just get started with something and get movement and get momentum.
Thanks. Before I give the floor to Anupama, I have also a question follow-up on implementation, and it's actually if you foresee, because at the moment it will be like a PDF that I foresee to be attached to an email, or do you foresee at some moment to have some kind of record of its use, or do you plan to track this?
Well, for now, because we have the end of the funding period and the end
Mhm.
of our grant in August 2027, for now it's mainly feasible to stick with the PDF and also kind of see what the experience is with it, so we can refine
Mhm.
it. Our first starting point would to make it just to make it available on our website also for download, and
Mhm.
for filling it out maybe with just Adobe Acrobat or something, and then have for different working groups different passports, so to have like maybe if it's a 2-page thing, and this still needs to be a little bit refined, if it's a 2-page passport, to have 1 page with basic data, which stays the same for every patient, and the second page with the disease specific or disease group specific questions that will be relevant for this person in specific. And then we move forward from that and see how can we
Okay.
make it more accessible than later.
So for a later stage, maybe. Okay, thank you. Anupama, please, we have 1 more minute.
Thank you to Anna and Ines for answering my first question. In short, it sounds like the passport is supposed to do what in future EHR is planning to do. That's what I'm getting. And we needed a passport because electronic health record is not yet standardized, and it is being worked on from a pan-European view. So I guess it will take a few more years till we get there. So my second question is actually, did you also survey the other relevant partner of chain of care? For example, insurance companies, or when the government is the payer, also other paramedic professionals, and as Kirsten mentioned, psychosocial workers as well. So the other stakeholders in the chain of care. And here I will give a practical example. It's not just healthcare professionals. Sometimes you change insurance companies or for some reason. And this I experienced firsthand. And sometimes you have to go through a whole process all over again. So what are you thinking about surveying these stakeholders for transitional passports?
So thank you for your question. It's a very valid point. And regarding the at least other stakeholders involved that are also in the clinical aspect, like for example, the paramedics and stuff, we would really highly appreciate their input too. It's just really hard to get a hold of them to fill out this survey because our contact points are mainly the clinicians or the EPECs. So we've mentioned when we reached out to them for them to please forward it to any other person involved in the process, like the psychosocial helpers, workers, or the paramedics and stuff. So they fill out the survey as well. Getting a hold of them is a little bit more difficult than we would like it to be, but it's also something that we want to keep in mind. And as far as the payers like government and insurances, for now at least, and please correct me if I'm wrong, Simba and Carsten, the main goal of the passport is a clinic and patient perspective. So we want to support the transition for the clinicians and for the patients. And this is what's important for us right now. If the scope gets higher, and then maybe an integration the electronic healthcare records, or if this gets any bigger, this project, then yes, it's definitely relevant to survey these stakeholders as well to see how can this be implemented then on a larger scale. But for now, for our purposes, this did not seem a relevant point yet, but it may be in the future, and then that's definitely something we want to consider as well.
I definitely 100% agree with Anna's point. So as mentioned, our next step is to basically design the passport in line with the feedback, received from clinicians, and we will also involve youth panel members at this stage. When we have something available as a draft, we are thinking of sharing this with working group members. which are basically clinicians, and we will ask them once again to, clinicians, whether they can share within their team with the psychologist and I don't know, gynecologist and other team members, so that we do not miss any important information in the content of passport. So this is one way for us to move forward. But as Anna mentioned regarding health insurance providers, I think this is something quite difficult for us to reach at the moment, because so far the involvement was mainly across ERKNet network.
Thank you so much for the question, and thank you all of you. Karsten, maybe if you can be
Yeah, if I just may
short,
add
yes.
something, I would be wary with just counting on the integration of the European electronic health records, because if I really challenge you to open up electronic health record of a patient with a rare and a complex disease. It's not just one letter, it are thousands letters of physicians that are included there. So if we integrate the electronic health records, it will still be difficult for adult physicians to have access to the most important data at the first consultation. I think a transition passport is a way to structure like the most important data to make sure that that information is at least transferred. So I think even when the electronic health records are indeed integrated fully throughout every healthcare service, it's still important to have a concise and structured way to communicate information between a pediatric team and an adult care team.
Mm-hmm.
Yes, especially
Definitely.
for yeah.
Thank you so much, the three of you. We will now give the floor to our next speakers, another piece of the puzzle. So we will look now into building capacities and how ERN RECONNET and ERN RETA have co-developed training on transition of cares. And we have Silvia and we have Moja here with us. So if you can please share the slide, the floor is yours.
Thank you very much. Moika is in the background with the technical aspects. Great. So thank you, Robertis, thank you, Ines and Nora, for this opportunity for talking about the great effort we are doing between ERN RECONNET and RETA. I am Silvia Aguilera, and I'm a patient representative for ERN RECONNET and a patient myself. I haven't personally been through transition, but I am in contact as a patient representative with those who have been. And I have to tell you a little story about why transition matters for me so much. So I was then in the European Rheumatology Congress in 2024, and I assisted to a transition session with only dedicated to transition. And I heard a number that really scared me, which was that for pediatric rheumatology patients, some countries lose up to 50% of these children in transition. And I couldn't believe this. I couldn't believe that our system would fail our children so much that they would get lost in the system and no one would do anything about it. They just do not go back to the doctor, or it's too complicated, and we just lose these patients. And when they come back into the system, some of them have flares. We're talking about children with lupus, with very complex rare diseases. And not even rare diseases, like we were talking about rheumatological diseases. And I thought this was just totally unacceptable. So when Moika and Tadej and other clinicians from RETA and RECONNET came looking for someone for patients to help during this training for transition, I could just not say no. So as Moika will tell you after, we were a team, a very multidisciplinary team with pediatric rheumatologists, but not only, and we were 2 patient representatives. So it was me and Michael Potts, that is also a father of small children that will go through transition. And the experience during this course, which Moika will now go into very detail saying what we did, the patient voice was considered at every step, and even more, every time that there was a question or a doubt, they would turn to us and ask us directly, what do you think? What would you do? What would the patients would like to see in this course? So I have to, I'm really proud. I'm very happy to have participated in this. And I think that as we saw yesterday with Jane, with Aurora, the challenges like today we have seen, and not everyone like what are working like Eduardo and Esther in San Juan de Deu, that we have really good examples in some hospitals that this is working very well. Sadly, this is not the case everywhere. And the idea of this course is to make like ambassadors of people that are wanting to push for change. So they get this training, and then they will be able to move these little pieces that maybe will make the change for transition to be better for these children. That I think we have still a lot of work to do. So Moika, go ahead, and then I will interrupt you if I have to say something in the meantime. Thank you.
Maybe you are
Hello.
muted.
Hey,
Yeah.
hello. So, as you already heard, my name is Moica Zajc-Avramovic. I come from Ljubljana, Slovenia, and I'm a pediatric rheumatologist. So I will show you how we, by consensus of methodology, tried to develop the ERN RECONNET training framework for transition of care. So we already heard about facts, what transition can happen, what can happen with transition. So there are a lot of risks associated with this vulnerable period in children's and young adults' lives. So they either stop taking their drugs or they stop coming to the doctors at all. And all this leads to a lot of adverse consequences for morbidity, mortality, and for different outcomes of the disease. And we have to say that these are the diseases that we now know how to take care of. So the pediatric doctors and the adult doctors, we know how to take care of these diseases, just we get, our patients get lost in this process. So we are part of ERN RECONNET, and RECONNET is ERN for rare connective tissue disorders. And inside of the ERN RECONNET, there was need for transition and for transition task force. And this was actually issue raised by patients. So a couple of years ago, the task force was established, and we are two centers leading this initiative. So here is Professor Gabriele Simonini from Florence, and this is today from my hospital, and we lead this team together. So for us, it was very important when last year in Prague on the second ERN RECONNET Congress, we made a small survey among the participants. You can see here there were 45 of them. Most of them were adult rheumatologists. And we asked them, so why are you not implementing the transition guidelines that we already are all aware of that they exist, but they're just not implemented? And well, half of the people answered because we have no training. So insufficient training of healthcare professionals was a very important reason that the guidelines that we have established are not implemented. And we asked the participants, have you had any transition training? Well, just 2 persons said they had some transition training. All others said they had no training, or they just learned by doing, or just didn't have any training. But because this is something that we all have to do, we just feel that we are good at it, I guess. Because either if you're a pediatric doctor, you need to transfer your patients. And if you're an adult doctor, you receive also younger patients. So this is a very important area of our work that we all do, but we have no training. You know, we are trained in basically every other part of our job, but not in this. So in November in Ljubljana, we had a transition training workshop. So we tried to develop the consensus framework for the training of transition. So these were our methods. First, we shared some prepared materials, we did literature review, and we were quite happy that just before our course, the WIMS transition training ETRs were published, and we got quite a lot of ideas from that ETRs. I invite everybody to look at this very, very informative paper, but you also use the CanMed's roles, and these were the materials that all the participants got in advance. And then we divided ourselves into expert groups where we identified essential domains and we identified essential core teams. We had quite a lot of time to discuss in these expert groups, so all opinions were heard. And this was followed by plenary sessions where different groups presented their views, what should be the essential domains and core teams. And after that, we had moderated discussion. We had methodologists also in our group. So after that, we had consensus voting, and we needed, so for core teams and domains to be confirmed, they had to be confirmed with over 80% of agreement threshold. After that, we had some post-consensus refinement, and this was mostly aimed at the competencies. You will see that a little bit later. And here is our transition training expert group. There were 18 voting members. So we came from pediatric side, from adult side. We had some experts that are dealing with pediatric and adult care. We have two patient representatives. So one was a parent and one was a patient, as Sylvia told you before. So we had a WIMS specialist for adolescent medicine. So she was actually leading these ETRs in the WIMS transition paper. We also had a primary care pediatrician and an oral health specialist. So we came from very different RECONNET members and from very different European countries. So here you can see the final framework of our for transition training course, and we built some sort of hierarchy. So we have 7 domains which cover broad areas of expertise, and below this are 25 core teams. And for us, the most important thing probably is that all of these are associated with 68 competencies, and competencies are measurable. This is measurable knowledge, measurable skills, and professional behaviors that we can check in the trainees and see if they have accomplished this, and if they are now good to go and do this because they have learned and showed that knowledge. So I will just go shortly through the domains because it's too much work to show in a very short talk. But our first domain focuses on principles of adolescent and young adult medicine. So we call this AYA. And why I think it's important to show you the different domains, because you will see this can be also then transferred to adult rare diseases. Now we will focus on the disease that ERN RECONNET deals with, but you can easily transfer this to other fields of medicine, because there are just some that are associated to specific diseases. So in the principles in adolescent and young adult medicines, here are the core themes of developmental aspects, and then AYAs with chronic conditions. A special core theme is associated to family dynamics, mental health, and vulnerable and distinct subgroups. The second domain is specific for rare connective tissue diseases, and in other fields of medicine can be associated to the specifics of other pathologies. So here we deal with trajectory of rare connective tissue diseases from childhood to adolescence and adult life. One core theme is reproductive health, and then the therapeutic adaptation and management in AYA, and followed by preventive medicine and comorbidities such as vaccination and healthy lifestyle. The third domain is the one that's focused more narrowly on the transitional care. So here you learn about different models of transitional care. You can find the one that's most suitable to your institution and your environment. And of course, transitional care planning and readiness assessments are part of the 3B core team. We developed a core team of multidisciplinary team collaboration because we feel this is essential to the good transition of care. So to connect in one team all the experts that deal with this. So not just pediatric doctor, adult doctor, but also nurses from both fields, doctors from other comorbidities such as, for example, ophthalmologists, orthopedic surgeons, physiotherapists, social workers, whatever it's needed. Psychologists are also involved here, and we feel this is one of the most important core teams to do good transitional care. And of course, after that comes transfer and continuity of care. Here we don't want to stop just with transfer. So, you push your patient to the adult doctor, but we also want to learn the feedback. So what happened with our patient after they went to adult services? So in a way, how can we improve our transitional care? The fourth domain is completely devoted to communication. It has been a very, very important topic. And here we have different layers of communication. So communication with our patient, communication with the whole family. We can't, omit the family when they go to adult doctor. We want to keep the family in this circle. And then, because we are dealing with a multidisciplinary team, we also have professional communication. So professional communication with your team and, above your team. E-health, digital technologies, and telemedicine are important topics when you're dealing with AYA. So this is also associated with health literacy that we put in this communication domain. The fifth domain is health advocacy and patient partnership. And we want to advocate for our patients, for their diseases, but we also want our patients to advocate for themselves. So we want them to be able to self-manage their disease. We want them to be empowered and to be our partners in this leading and managing their diseases. The sixth domain is associated to ethics and legal aspects, so ethical principles in AYA care and legal aspects change in this period of life, so topics such as confidentiality and consent change a lot in this period, and the trainees need to be aware of it, and also of different aspects in different EU countries. Equity, inclusivity, and cultural sensitivity are also a specific theme in the ethics and legal aspects domain. Our last domain is implementation and quality management, so how to implement your transition of care process with your institution and with your national health system. And of course, we can't go without quality management, so the constant circle of planning, doing, checking, and then analyzing and acting of our results. So continuous improvement is an important part of every process that we want to have. And continuous professional education, of course, for every healthcare professional, this is an important topic. We can't just stop at educating ourselves, but here in the broader context, we also put the continuous professional education of our colleagues. So those that maybe, as Sylvia told you, we want to build a network of professionals that will keep pushing this topic forward and educating their colleagues. So, in conclusion, transitional training is increasingly recognized as needed because there is lack of knowledge and skills on all sides, so pediatric and adult. And in ERN RECONNET, so far there has been no training of professionals in this field. So we have the final transition training framework built of 7 domains, core teams, and measurable competences. And the most important slide, there will be a first transition training course that will take place in October in Ljubljana, Slovenia. So this will be a 3 days live course, which will be after that followed by online sessions where trainees will be meeting with their mentors, discussing their specific cases. This will be an EACME accredited course. So it will be also, of course, exam at the end, and your mentor will give you some sort of evaluation. And registration will open real soon. We have established a portal. We are just waiting for some final confirmation. And this will be a course that is covered by RECONNET. So registration will be completely free for all participants. And we also applied for some additional funding also for costs for lodging and travel. So you can visit the RECONNET site or you can subscribe to newsletter and you will be informed about the course. So thank you and welcome.
Thank you so much, Moika. Thank you for sharing not only the content of the course, but also how you arrived to have all this and how you co-created to have this knowledge in one course. And do you have any questions in the audience for Sylvia or Moika? Not yet. A lot of clapping though.
Yeah, we are very happy that we were able to develop some sort of more practical approach, not just, there's a lot of talking about transition, but we want to establish some sort of a practical approach, practical course, what you should know when you start working with patients, when you start transitioning them, how you should do them. Because, some people are more likely to talk about different topics with their patients and some people are less likely. And if you're not taught in a structured way how to do this thing, then you will never improve. So we feel it's important that this topic is getting recognition, that it's getting visibility, This is the only way to improve it. I think if we advocate for this topic a lot, you don't need so much funds. I think, you know, on the we showed this project not long ago also in another hospital, and the topic of funds came along. But I don't think you need so much funds for this. You just need good communication and people who are aware of the importance of this topic.
And Silvia and Moika, maybe one question. If you were to give an advice of maybe another ERN that wants to follow the same path and start a module on transition, what that would be?
Well, we will, of course, publish this consensus framework, and we are very happy to share this with other ERNs. ERN Rita already somehow joined, and we will do this a little bit together. And I think the important thing is that this course and from consensus framework is built on the basis that you can really easily divide to our other ERNs, because this is how we built it. One domain is completely dedicated to rare connective tissue disorders, but everything else can be, you know, somehow applied to other fields of medicine. So I think it would not be so difficult, and we're very willing to share everything that we did to help, you know, other ERNs.
That's great. Thank you so much.
I think if I just want to highlight something that Mochka said, is that I think there was a lot of discussion about domain 4 and 5 on communication. We thought it was very important to train the participants into how to communicate better with patients and how to communicate better with families as well, and between different professionals. So there is really a module there about how to improve this, that sometimes we see that, you know, there's maybe there a gap into how to communicate with different partners, but also domain 5, which was health advocacy and patient partnership, was very interesting because we had a very big discussion about if we should teach participants about advocacy. And we decided no, that this was not the place for clinicians to bring out the patient advocate in their patients, although this would be very good for us. But it was more to encourage these young patients to advocate for themselves, for their health, to become their own advocates, and you know, at least in this, just for them, not to become patient advocates, but in front of their teams, in front of the doctors, in this period where a lot of is going on in the life of a teenager and adolescent, that they can really advocate, and how to self-manage and how to be empowered as a patient, and to really seek this patient partnership with teams and with clinicians and nurses and care teams. So I'm very proud of these two domains, particularly, which included lots of discussion and consensus.
Thanks, Silvia. And I see the chat now, and I think it's a bit like we have a question from Diana to you, Silvia. Do you think that the ERNs could start building some kind of training also for patients and carers? Could be that useful?
Thank you again. I think it's a very good idea, because I think also from the patient and family side, we go into transition with a lot of expectations and a lot of dreams, and I think this should be handled better after families are disappointed. And as I said before, in some disease areas, we lose up to 50% of patients. And I think managing expectations and knowing what is ahead, and knowing that it maybe in some cases, in some countries, maybe it's going to be harder than in others. I think we should really maybe think about this as well, about talking more about transition, maybe do a little course on patients. Maybe this should be, but really maybe nation specific, because even in Spain, where I have my experience from region to region, because we're like 17 little different countries, it changes completely, and it is totally different if you're in a big hospital or in a rural area, and this is a totally different story. But this is, yes, a very nice project that Diana, maybe we could think about for the future.
Thank you so much, Diana, for the question, and Silvia. We have to close here for questions for Moika and for Silvia. We will have the recording of both webinars published in the website. I will now post the link in the chat. Meanwhile, I do that. I would like to give the floor to Ines. She will be making some closing remarks of this series of webinars.
Yeah, thank you, Nora. Are we over time, or are we good?
You have a couple of minutes.
A couple of minutes, that's a lot. No, so I just want to, well, first, thank you, because this, these two webinars were really conceptually built by Nora, and she was the one kind of bringing together the speakers and the whole concept, let's say, and her idea. And I think that we have achieved it. Well, yeah, actually, yes, the objective has been achieved. So her idea was that we would go beyond really talking about the needs on transition and the survey results, more into practical things and into things that could be more kind of short-term implemented in the clinics. And I think that has been achieved because we've got lots of good examples today. And also yesterday we had a good discussion around what it takes to measure all this. To be honest, it's not easy. I mean, these are all very good ideas, but when you go to the ground and you go to the health systems and you try to capture those 50% that got lost, let's say, is not easy to even capture that information. And that is very important that we are all aware of that. It's also very important that we are all aware that, this transition happens in health system, in the ground, where the person leaves, the family leaves, and all this is really important. And that we are all aware that everything the ERNs are creating, curating, and putting together, I do think that is the first stone for having a good quality health care experience in the countries, once we manage to integrate the ERNs into the national health systems, and once we manage to get health authorities to look at what ERNs have done and to adopt it at national level. This is my dream. I hope we will get there. But everything you're doing is so good and it's so brilliant that I really really thank you for presenting it today. We'll come back to you maybe next year to see where ERNICA is and where where are you with all these projects, and if there has been any follow-up. But really, thank you from really my heart, full heart goes to all of you. And yeah, I just wish you a good day today and a nice summer break if you're about to take it. Bye, everyone.
Bye. Thank you.
Thank you. Bye-bye.